I'm Arif Hussain. I'm an oncologist at University of Maryland Greenbaum Cancer Center. I'm a professor of medicine here in the School of Medicine. My area of specialty is genitourinary cancers. In this country, over 54,000 patients have renal cell cancer. To put this in perspective, there are 1.4 million new cases of cancers, excluding squamous and basal cell cancers of the skin. Among genitourinary cancers, which includes prostate, bladder, testicular, and renal cancers, the most common is prostate cancer, but renal cancer is the third most common cancer among genitourinary cancers. Most of the trials have been done with clear cell renal cancer. There are 5 or 6 different subtypes of renal cancer, but the majority are clear cell, and most of the trials have been done in clear cell cancers, although some of the patients in these studies have had mixed histologies, so they could have a component of clear cell with some of the other non-clear cell histologies. Well, it depends upon how patients present. If they have localized disease versus metastatic disease, what's happened is in this country there's been a remarkable stage migration of the disease so that more and more patients are presenting with organ-confined disease, as opposed to 30, 40 years ago where a greater proportion of patients had metastatic disease. So if it's organ-confined, then the treatment of choice certainly is surgery as first-line therapy, which can actually be curative. On the other hand, if it is metastatic disease, the trend often, in this country at least, is to do a nephrectomy, meaning to remove the kidney before undergoing systemic therapies. Well, I think in terms of the treatments of renal cancer, it has really undergone a remarkable evolution in the last 3 to 4 years. Now we have, in this time period, 6 new drugs that have been approved by the FDA, when for the last few decades, we didn't really have anything except for cytokine therapy. Of the cytokine therapy, there are 2 types essentially, interferon and high-dose IL-2 or interleukin-2. And of those 2 cytokines, high-dose interleukin-2 was the only FDA-approved regimen for metastatic renal cancer. Not very effective. Response rates were about 15% in metastatic disease with 5% complete remission rates. So that was the standard against which new treatments were being developed. Chemotherapy generally does not work in advanced renal cancer. So in the last 3 to 4 years, there has been a paradigm shift in that now the most common type of cancer, clear cell, is being treated with targeted therapies. And the drugs that have been approved are the so-called targeted therapies, which include both oral agents and intravenous agents that have been approved by the FDA. In terms of the targeted agents, the first drug that got approved was in December 2005 by the FDA. It's an oral agent called sorafenib. It targets blood vessels. One characteristic feature of renal cancers is that they tend to be very vascular, which means that they have a lot of blood vessel growth. That's due to some genetic lesions that occur in the kidney cancers. So most of these drugs target blood vessel growth or new blood vessels. So sorafenib was the first drug approved in December 2005, and perhaps the largest randomized clinical trial done in patients who had failed cytokine therapy. The primary endpoint of that trial was to see if you could increase progression-free survival of patients compared to placebo, and in fact that was achieved. The second drug that was approved was sunitinib, which it turns out as first-line therapy is probably, at this point, perhaps the most effective agent, producing high objective response rates in the range of 35 to 40%, where we've never seen these types of response rates in the in the past with interferon or interleukin-2 therapy. And the progression-free survival has actually doubled compared to interferon. Subsequent to that, another drug got approved, which is Toracel, which was approved in March or June of 2007 by the FDA as first-line therapy for advanced renal cancer. That drug is an intravenous drug, as opposed to the Sutent or sunitinib and sorafenib, which are oral agents. So these are the three drugs that achieved approval, but more recently, Avastin in combination with interferon has also been approved by the FDA in the US. In Europe, Avastin interferon was approved earlier than in this country, and this is based on two large randomized trials comparing Avastin interferon combination to to interferon alone. And in those trials, a clear advantage to the combination of Avastin and interferon was demonstrated compared to the single-agent interferon. And more recently, just in the last month or so, another drug called pazopanib has been approved as first-line therapy in metastatic renal cancer. Last year, Afinitor, which is related to Toracel, was approved in patients who fail first-line targeted agents such as sunitinib or sorafenib. So that's the range of the drugs that have been approved so far. In a nutshell, what we have is 6 new drugs that are available to the clinicians over this time period when before we didn't have much. Now the question is, how do we optimize these drugs? How can we use them sequentially? If patients fail one agent, what would be the next drug to use? Some of those answers are being obtained through ongoing clinical trials. The other question is, now that we have somewhat more effective therapies than we did previously, can they be used in the adjuvant setting in patients who undergo nephrectomies, but they're at high risk for recurrence? So could these agents be used in those patients in the adjuvant setting to decrease chance of recurrence in the future? No, I don't think so. The combination of interferon with bevacizumab, response rates, progression-free survival, duration of response seem to be to parallel or mimic that of the single-agent tyrosine kinase inhibitors. Now, the question that has not been answered, and I don't think will be answered, is what is the contribution of interferon when added to the bevacizumab? In other words, would you get similar response rates with bevacizumab single agent compared to bevacizumab interferon? And those studies probably will not be done. However, bevacizumab is being combined with Toracel, for instance, and sorafenib to see would those doublets have better outcomes compared to single-agent bevacizumab. So will bevacizumab and interferon replace some of the other first-line targeted agents, the tyrosine kinase inhibitors? I don't think it will.